We have a 30-bed med-surg unit, and 95% of those patients are medical. Flow has been started on med-surg, and we are now spreading over to ICU. The goal being that we want to be visible throughout the organization, so it doesn't matter where you go, whether you're the physician or the nursing team. It's the same on all units, that you talk about the discharge planning, what is it what are the barriers to discharge, and how can we meet the needs of the patients in a timely manner. Our bed turns, I think I'm the most excited about. When you consider that on average we'd been experiencing at least 10 ALCs on our 30-bed unit, and so then we only had 20 beds to utilize. So out of those 20 beds, from the time of October to December, we've been able to turn those beds 24.5 times when our target was 23. So I'm really excited. On 20 beds, we've been able to do that.
Okay, so in order to improve bed utilization and decrease length of stay, we needed to look at improving communication with patients, families, and our team members, our care providers, and provide clear expectations on care provisions and discharge planning, and develop triggers to care providers early in the admission process, so physio, OT, dietary can get involved right away. For one change idea, we added, like I said before, the main whiteboard at the nursing station, and the bedside whiteboards to all units in the organization. Well, we've put it in the ICU and down on 1 South as well. And we've also changed weekly bullet rounds to daily, which does put discharge planning right on the forefront. Communication is open. We engage nursing, all of the disciplines if they can make it, and most have been pretty consistent with their attendance.
Our bed turns, as I said, we're going to continue to monitor those, and we're very pleased with the number of beds we've been able to turn. And then I mentioned earlier about Flow, how it's added value to other areas, and with ICU, it's kind of a busy graph, but we went back from 2008, 2009, and now beginning in 2010. The number of patients who were sent from ICU, which is a 5-bed unit, to emerge because there was no beds on 2 South, or went to the overflow bed in ICU, has decreased significantly for us, that we're really pleased. At some points we're 0. Starting out this year in 2010, we're back over to the left side of the graph in January. We're already below where we were the last 2 years on the number of people who've been transferred to emerge, which is not the best place to send an ICU patient. So we're happy with that.
And before I get into the sustainability, I wanted to mention we also take stats of the main whiteboard. We want to measure our, I guess, predictions, our predictability. Are we predicting discharge? So every day during bullet rounds, I write down when a patient turns yellow, and then I monitor their discharge. Did we predict that accurately within 2 to 3 days? So we are predicting and keeping statistics on to how well we're predicting things. Did a person go red to green and then discharged, and we didn't have any idea they were being discharged? So we're monitoring that as well. So our initial sustainability survey was in April 2009. We had a score of 73.6. We repeated it just in August 2009. We had 78.9, and we just did it in January 2010, and we're up to 94.9. So this is improvement. It reinforces our confidence in the success of what we're doing. The majority group involved in the second and third survey were a bit different from those who completed the first. It was identified by the group that engagement through the organization is evident. We're still utilizing the PDSA cycles, and we anticipate as new changes are implemented, our score may change in response to reflect perceived adjustments being required by the team. Okay, plans are underway. We'd like to engage the physicians a bit more. We have an idea of designating a stoplight color on admission. So with the admission, they would identify red, green, or yellow, and then that would be communicated on our main whiteboard. We're currently investigating the feasibility of phasing out our physician's communication book and have our whiteboard as one-stop shopping for them. Write all the needs up on the board and have the physician look up on the board rather than in their communication book. And we were also improve the transferring of color designation of ICU patients who are transferred to 2 South. Sometimes I go up to the board and there's no color by a patient that has been transferred from ICU. And so we're trying to look at the process and see why is that happening? Why are they not transferring the colors? So we're looking at that process as well. And we continue to provide regular updates to team members related to stats and flow education. Through newsletters, team meetings, Kelly posts stats up by the whiteboard so all members and nursing staff can take a look. Flow group, we continue to meet regularly, and we provide highlights report to the leadership team, and we've done a presentation to Tillsonburg Hospital Board of Directors.
So some of the key successes, leadership support I think is key, definitely, to the success of the project within the organization. As well, the leadership partnership that we experience with CCAC in the hospital, the cohesiveness of the partners that are involved in the project, and the readiness and enthusiasm of the team. It just happened to be, as I said, the right time. We had to make some changes in the organization, and this fit very nicely with our aging at home strategy. And I think the flexibility of the team to be able to adapt to the change on the floor so far has been good. And as Vicky had said, we do have a high sustainability score right now, but we predict that it might drop as we try and introduce new changes, and we'll keep on top of that as well. And we continue to reevaluate what else do we need to do to make improvements and maybe change our course. Some plans that we have underway are engaging the physicians and designating the stoplight color on admission. We are looking at, right now, because we have this doctor communication book, that maybe we would add in there our length of stay and our color change while we're waiting for our 2 physician inpatient advisory members to take forward the suggestion of using the main whiteboard and getting rid of the communication book, because that's one of the things, is taking away something that the nursing team has to do to be able to have one go-to place. If you're going to add something, you got to take something away. So we're hoping that we'll get some buy-in, and actually the physicians that I spoke with were actually excited about that, because they have to fight over the book with their colleagues in order to get at it. So having it at the whiteboard and all their information there would be a benefit. So hopefully they'll be able to sell it. So as far as the daily bullet rounds, I think that is probably one of our key change ideas that has been the most successful. Everyone has something to contribute, and especially nursing. It was very, very important that we had nursing at the table, and to have it every day with just the physicians isn't effective. We have to make sure we have everyone's involvement. So what would be our recommendations for new teams who might be just beginning this journey? Susan kind of touched on most of the things that I had already had in here as well. Engaging key stakeholders, and especially the nursing and physician groups, early in the process, and identify what's in it for them. Providing education sessions prior to beginning the process. And you know, even though we didn't have the education prior to starting, we just we did informally through the mentorship of STEG and getting things rolling. But just the data gathering and getting our stats was maybe something that in hindsight would have been nice sooner rather than later. But you know, we're doing okay. Providing, engaging the providers throughout the organization and throughout the change process itself, and making sure that we have education sessions for the board, for the team members at large. We did a lunch and learn. We had Jennifer come in and do a lunch and learn for the team when we first rolled things out. And being flexible and open to change, and getting input from the team, and not being, you know, digging your heels in. You have to be able to listen to what the team says, take their ideas and move it forward. That helps with the buy-in. And just recognizing that there's times that it's going to be taking, you feel like it takes too long to implement something. And I think that sometimes you feel like your wheels are spinning, that aren't we getting anywhere? A good example is our admission database. We feel like we've been working on it for a long time, but it's okay. That's part of this whole PDSA, and trying to, you know, you try it, and then you try it again, and then you try it again, and change, and don't be discouraged. I think that's the biggest thing. Don't be discouraged that you might be not moving as fast with some things rather than others. That you just got to take a step back, refocus, regroup, and above all, don't give up.